Welcome to Grand Rounds for June of 2025. This month we have Dr. Elizabeth Scifers talking to us about shoe updates. Dr. Scifers earned a Doctor of Physical Therapy degree from Murphy-Deming College of Health Sciences at Mary Baldwin University and a Bachelor of Science in Athletic Training from Western Carolina University. She completed her residency training in orthopedic physical therapy at St. Luke's University Health Network and is board certified in both orthopedic and sports physical therapy. Dr. Scifers is a faculty member in both the orthopedic physical therapy residency program and the podiatry residency program at St. Luke's. She serves as the Director of Clinical Advancement for Foot and Ankle at Foot Physical Therapy at St. Luke's. And in this role, she is Program Manager of the Foot and Ankle Rehabilitation and the new Founding Director of the Foot and Ankle Physical Therapy Fellowship Program at St. Luke's University Health Network. Dr. Scifers' research and clinical practice specializes in foot and ankle management, gait analysis, and orthotic prescription. As usual, please make sure that you sign in with the QR code on the right side of your screen or the code on the left side of your screen. Let's see here. This is the medical credit information, the statement of need, and the target audience is for all providers. This is our designation statement, and the planners and presenters have nothing to disclose. Without further ado, I will turn this over to Dr. Scifers.
Thanks, Steve. So here are my learning objectives, but goal of this talk is so at the end of it, no matter what type of clinician or provider you are, you feel confident in describing the anatomy of a shoe and being able to prescribe a traditional shoe to your patient, no matter what their pathology or foot shape is like at the end of the day. All right, so my first question for you, Steve, are you able to check on the chat at all? Actually, okay. So if anybody would like to participate, this is the only moment I'm going to ask you to participate for now until we get later into the presentation and into questions. But if you had to describe what a good shoe is, this is a question that I'm asked all the time by patients. They walk in the door and they say, "What is a good shoe? What kind of shoe should I go out and buy?" So if you had to describe what a good shoe is to you, what would you describe?
And if you'd rather not type, just unmute yourself and speak up.
Anybody willing to take a stab at it?
A shoe that has a wide toe box. So
Okay.
guide rails, foam. Those are two different answers.
Okay. Yeah, those are some different describing features. So we're going to talk about all those features in the shoes and when they might be beneficial.
Another answer is I always test running shoes by seeing how much I can bend them.
That's a great point. We're definitely going to talk about how to test them in the future.
And the next one is a shoe for your specific foot, arch, and gait.
Exactly. So this is one of those great it depends type questions, right? And it's such a loaded question when patients walk in the door and they say, "What is a good shoe?" Well, I need a lot more information about their gait analysis, about their foot posture, about their injury history, about potential pathologies they have going on, about activity level, what they ultimately need to do with the shoe. So just describing a shoe in general that could fit every type of foot and every population, that doesn't really exist. But hopefully at the end of this talk, you're going to be able to describe the components of shoes. You're going to be able to describe the anatomy of a shoe, and you're going to feel confident prescribing shoes no matter what type of patient is in front of you. All right, so the next slide is going to take you through the anatomy of a shoe. One disclosure I will give you at this point is that I have a ton of shoe brands throughout this presentation. I am not proposing that you buy any one shoe brand, but I'm trying to give you an idea of what current shoes look like on the market. So I'm going to give you a variety of different shoes, of things I like and don't like about all of them. But so you'll see in this image here, there's the Hoka shoe, which is super popular today on the market. So that's why I chose it for this image. Some things you have to be able to understand in terms of being able to prescribe shoes is basic anatomy. And for the most part, this stays standard across shoes, even though shoe construction is constantly evolving. So the upper material is anything that you see when you're looking from the top down at your shoes. So if you look down at the shoes you're currently wearing, that material on the top of the shoe is going to be the upper. Most of these other components we're going to talk in a little bit more detail on the next few slides. In the back, you have the heel counter. This is going to be essential for rear foot control of the shoe. And again, we're going to talk about that in a little bit more detail in the future. The insole can actually have a variety of names. So depending on where you learned this material, you may have also heard this called an inlay or a sock liner. Inlay tends to be more of a UK terminology. So again, depending on where the provider was trained or what their background is, they may call it an inlay. So insole, inlay, sock liner, those are all the same thing, but this is the portion that actually comes out of the shoe in most cases. But important that you know whether or not it can come out of the shoe, because that's going to be important for orthotic prescription if you're prescribing an orthotic to go in that shoe in the future. Outsole is what you're traditionally thought of as the sole or the bottom of the shoe. Heel to toe drop has been a really hot topic over the last few years, and patients often come in and they say, what heel to toe drop should I look for? And there's definitely been a swing towards minimalistic shoes where that heel to toe drop is almost nothing, all the way to maximalist shoes where that's a really high heel to toe drop. So it is important that you know how that'll affect the Achilles, link tension relationship, and other components of gait. And again, that's going to be very dependent on the patient in front of you and what's the appropriate thing for that patient. Somebody already mentioned toe box. So the toe box needs to minimally be wide enough to allow for the toes display in order to get good intrinsic activation. So this is something you're going to want to educate patients on. And again, dependent upon pathology, you may want this to be wider for certain patients. And then lasting essentially describes how the shoe is constructed. So there's an inner lasting in how the shoe is constructed on the inside and put together, and then there's an outer lasting and how the shoe is put together on the outside. All right. So now that you have that anatomy, we're going to dive into a few of those components in a little bit more detail. All right, so this next slide I know looks a little bit busy right off the bat, but I'm going to take you through the whole thing. All right, so the heel counter is essential for rear foot control, right? And this portion, if it is not stable, will not provide biomechanical control through the rear foot. There are a couple important things that you need to know about the rear foot in terms of control. If it's not stable, again, it's not going to provide good biomechanical control. And that bottom right-hand corner is that pinch test. And a couple of you mentioned that you like to pinch the shoes or potentially try to fold them up. In this scenario, I oftentimes teach patients who I want good rear foot control to grab the back of the heel counter. And the heel counter is going to be this portion that's at the very bottom here. So on each one of these shoes, this is where the heel counter is going to be. And this is what's going to provide that good rear foot control. It's not up here. So this is that Achilles collar at the top. This is going to be very nice and soft to help prevent blisters. This is not going to provide biomechanical control. So if your patient squeezes at the top where the Achilles is, they're going to feel a nice, soft, cushy material. But down here, you'll often see like a plastic collar or some rigidity, and this is what provides rear foot control. Some important things to note about rear foot construction that have changed over the last few years. About 5 years ago, almost every shoe on the market developed what we call a lateral beveling to the rear foot. So if you see this New Balance Fresh Foam and this Brooks Glycerin, they took a chunk off of the lateral rear foot here. And the idea behind this was that it would promote supination at initial contact. And what we know about distance runners is that even the most elite distance runners in the world eventually heel strike at some point if they're running long distances. So there's a great article that looks at these elite distance runners, and about the half marathon mark, almost every single one of them's heel striking. And we know that over those long distances, most people start to lack a little bit of eccentric control of posterior tib, glute med, and we tend to see a little bit of pronation as they start to fatigue. So the idea behind this was that in these distance runners in that traditional running shoe was if we force that supination at initial contact, then it'll prevent that excessive pronation. However, we know not every patient looks like that, and not every patient is running that level of distance. So not every person walking around needs that on the outside of their shoe. But about 5 years ago, every traditional running shoe on the market looked like this, which changed the way that I prescribed orthotics, because if I prescribed an orthotic with a medial post to correct the person who was excessively pronated and I put them in that shoe, I actually ended up causing a fifth met injury or a cuboid injury because then they loaded more of the outside of their foot. So it's important to know the type of shoe that you're going to potentially put an orthotic in so that you don't potentially create another injury. However, I will say I think this might be gone. The last few models of the New Balance shoes I've seen, and the last few models of the glycerins that I've seen, the last few models of Sauconys that I've seen coming out on the market have a much less pronounced lateral bevel to them, and it's getting back to that more neutral design, but just something to keep your eye out on in the future. And then one thing I'll show you too in terms of design that I really like in terms of rear foot control that I'm currently seeing, especially with the acceptance of an orthotic, is that Saucony guide, which is up here in the top right corner here. This Saucony guide, and you can't truly appreciate it, I think, from this view, but the actual rear foot portion down on the inside of the shoe is nice and wide, so it'll accept the orthotic really well. And what happens when we create an orthotic design for somebody who I really want to control the rear foot is I have to make the rear foot wide enough to allow for a deep heel cup for the heel to sink down in it. And what happens in traditional shoes is when I put that orthotic in the shoe, it then pushes out the rest of the rear foot, and then the patient doesn't feel like their Achilles or the rest of the rear foot is hugged in the shoe. But the cool design with this Saucony guide, and the new Brooks Glycerin has this as well, is this Achilles collar. So it allows for the depth of the orthotic, the width of the orthotic, and then it comes up and it kind of hugs the rest of the Achilles. And so patients really like that if you need to put an orthotic inside the shoe. They just kind of feel this nice snugness to the shoe, but it doesn't overcorrect them and it's not too tight. All right. So hopefully everybody's following me so far. I know that was a lot of detail in terms of heel counter, and we're going to dive into a little bit more detail in terms of shoe construction over the next few slides. And then we're going to put it all together in the end in terms of a couple case studies, okay? 90% of what you see in terms of lasting, so outside lasting, describes how the sole of the shoe is connected to the rest of the shoe. So 90% of what you see out there on the market is going to be a semi-curved last shoe, meaning that it has some stability. You'll see that it has a small curvature to it in terms of design, so there'll be a little bit of flexibility, but for the most part, it's a nice stable shoe. There are very few shoes on the market that are a traditional curved last shoe or a traditional straight last shoe. Your curved last shoe is the super flexible shoe. So if you can imagine that Nike Free, if you've ever seen one of those, and a couple of you mentioned in the beginning that you test shoes by being able to fold them up, a Nike Free is one that you could fold in half. You could take it and twist it through the midfoot, and this thing is so flexible. It provides no biomechanical control. Very few people should be in a Nike Free type shoe for activity, whether that's walking, standing, or running. Even those more rigid Cavus feet are going to have an excessive load because of the flexibility in that shoe. It's not a good shoe for the extremely Cavus or the extremely pes planus foot, or again for most people doing activity. And then on the other end of the spectrum, we have that straight last shoe. And I know it's a little hard to see here, but in a traditional straight last shoe, you can pretty much draw a straight line from the rear foot through the toes, and you can see that going through this Ghost Max. So the Brooks Ghost Max is what a traditional straight last shoe would look like. And this is going to be a pretty rigid shoe, and it's going to provide really good biomechanical control. If you're familiar with the Brooks Dyad, the Brooks Ghost Max has now replaced that shoe. So lots of people used to love that shoe in terms of a stability shoe, motion control shoe. It accepted orthotics really well. I actually talked to the Brooks rep at APTA's combined section meeting this year and said, I love that shoe. Any chance you're thinking about bringing it back? And they said, nope. Everybody on the market loves the Ghost Max, and that's what we're going with from here on out. I can't necessarily echo that everybody loves that based on patient satisfaction that I'm seeing, but that's what they're hearing across the board. So if you're familiar with the Dyad, the Ghost Max has now replaced that, right? But if you're taking your images here from left to right, straight last is going to be more rigid, more controlling. Majority of what you see is going to be that semi-curved last shoe. It'll have some varying levels of stability, but a little bit of flexibility to it, not as rigid as the straight last shoe. And the curved last is going to be extremely flexible and provides no biomechanical control. All right, then moving to the inside construction of the shoe. So this is how the sole is stitched to the rest of the shoe from the inside. There are three typical ways that this occurs. Board lasting, meaning that there's a board on the bottom of the shoe and it's stitched around the outside, providing stability to the shoe. This provides a little bit more biomechanical control than some of the other lasting materials, but this is the most common. Again, majority of what you see out there on the market in a traditional running shoe, walking shoe is going to be a board last shoe. The slip last shoe is actually stitched right through the middle of the shoe, and it doesn't have that board in the middle. So this is going to be a much more flexible shoe. And then the combination lasting, I typically see this in like high-end men's dress shoes where you have this rigidity in the rear foot. They might have this hard, almost wood that they're walking on in the rear foot, but then flexibility in the forefoot. So it's usually slip lasted in the front and then board lasted in the rear foot. However, this does sometimes occur in sneakers and it provides good biomechanical control through the rear foot, but allows flexibility through the forefoot. So if you have a patient that maybe that is appropriate for, you might want to look for a shoe like this. There are very few of them on the market. Mizuno is typically the running shoe that makes this. I see maybe one every 3 years where a patient's in that shoe, but it's actually an excellent made shoe for that person who only needs rigidity in the rear foot but needs flexibility everywhere else. All right, so now we're going to kind of get into some of the things that have changed over shoes, over shoe construction over the last few years. So one of the biggest things that we've seen go away is the midsole construction and posting. So I don't know how you all were typically taught to describe shoes or to break down the anatomy of the shoe, but the way I was typically taught to look for posting or midsole density and control is for a differing in color. So typically if you saw this darker portion in the rear foot or this darker portion through the midfoot, that would cue you to think that maybe there was a medial post there or some additional control through the midfoot. However, that is no longer true. There are all kinds of cool designs out there on the market, differing colors, and you can take that thought process and pretty much throw it out the window. And very few shoes on the market now have a traditional medial post. So we're going to talk, I think somebody on the chat earlier mentioned the guide rails. We're going to talk a little bit about stability shoes on the next slide. But 90% of what's out there on the market today is truly a stability shoe and not your traditional motion control shoe that has posting to it. And we're going to talk about what defines stability. But if you're looking for that traditional medial post, these are the only shoes I could actually find on the market that have that traditional medial post. And what I'm talking about by medial post is this material here, where again, you can see that darker material. This is an increased density of foam and it provides additional biomechanical control. So this might be great for that patient who has excessive pronation, and especially that early excessive pronator who then continues to excessively pronate through mid stance. This is going to provide more rear foot control when they initially strike the ground. All right, so now we're going to talk a little bit about stability shoes. So most of what's out there today is a stability shoe. And kind of what cued me to do this presentation and do some of this research was I was sending all these patients to our local running store and saying, go find a neutral shoe. Well, what I'm about to tell you is neutral shoes don't even really exist anymore. We used to describe shoes as that motion control shoe with the typical medial post, a neutral shoe that really didn't have any additional control, or that flexible shoe like the Nike Free. Almost everything now is considered a stability shoe, and they have some varying levels of stability. And the cool thing about the design is most of these stability designs only go into effect when you need it, which is really cool. So we're going to talk about how that works over the next few minutes. I'm going to break that down for you. So somebody earlier mentioned the guide rails. The guide rails kind of cup the rear foot and a little bit into the midfoot, and this provides both medial and lateral control of the rear foot, and they only go into effect when you need them. So it's essentially a neutral shoe, but if you start to excessively supinate or if you start to excessively pronate, then it helps to push you back into a neutral position. But it only does that if you move into those biomechanical errors. So otherwise, this could be a great shoe to potentially accept an orthotic, and it's not going to overcorrect your patient, and it's only going to be needed when your patient moves into that excessive supination or excessive pronation. And again, very, very few shoes out there on the market can help with that excessive supination. So it's really cool that Brooks developed this, and these are typically, the guide rails are typically seen in the Brooks line of shoes. to help correct those excessive supinators or excessive pronators. You can feel confident putting both those people in this shoe. Another really cool shoe out there is the Hoka Gaviota. Personally, I'm going to give you my own 2 cents here. I'm not a huge Hoka fan, but I will say that this Hoka Gaviota is a really cool design. So the Hoka Gaviota has what we call an H-brace system to it. So it has this medial bar and this lateral bar to it to control, again, for that excessive pronation and excessive supination. And then it has this bar through the midfoot here to provide extra midfoot support. And this is an excellent shoe for maybe that person who's had a Liz Frank sprain, or has some midfoot instability or midfoot arthritis. This is going to provide additional control through the midfoot. So if you've seen a patient like this could be an excellent shoe for that person. And then we're going to talk a little bit about carbon fiber in upcoming slides. But the On Cloud shoes in particular have a couple versions that have carbon fiber plates to them. And this could be a great shoe for the person who has hallux rigidus or potentially has a plantar plate injury, or some sort of toe pathology that needs some additional rigidity to help them push off. So consider that shoe if you need that. And we've already talked a little bit about the lateral beveling, but that's an additional portion of that control in the stability shoe. All right, I know that was super heavy in terms of contact and then that content and anatomy of shoes. So now we're going to talk about how you apply that, right? So now you're comfortable in describing the anatomy of the shoes and some of the changes that have occurred over the last few years in shoe construction. Now we're going to talk about when a patient comes in and talks to you about minimalistic shoe design or potentially maximalist shoe design, and maybe where you fall on that spectrum of what you think is the best for that patient. So what we know from an evidence standpoint is that switching from a traditional running shoe to a barefoot shoe, or to being barefoot, I should say, or to a minimalistic shoe that kind of mimics that barefoot running, that changes can be made in strike pattern. So if you have that runner who strikes the ground with their heel and you're concerned that that is increasing their risk of injury, switching to a minimalistic shoe or going barefoot is going to change the way they strike the ground. We know that that will force them to have this forefoot strike. So that sounds like a good thing, right? All right. And we also know that when switching to this barefoot shoe or this minimalistic shoe, that there has been seen an increase in intrinsic muscle volume or intrinsic muscle hypertrophy. So again, sounds like a good thing, right? However, I'm about to tell you 2 things in terms of injury rates that might change your mind. And take these 2 studies for what it's worth. They both have fairly small ends. But the first one looks at a 30-week training period, and they transition from a traditional shoe to a minimalistic shoe. And again, small N, only 14 people involved in this study, but 12 out of the 14 at week 5 reported an injury that altered their training level, a high enough injury that it altered their training level. In an additional study, increased bone marrow edema was seen in the Met heads after a 10-week training protocol where patients transitioned from running in a traditional running shoe to a minimalistic running shoe. And it is not recommended at this time for adolescent athletes due to an increased ground reaction force and a higher risk for injury in this population. So to kind of summarize, my takeaway on this, and again, interpret this information for yourself, but my takeaway from this is, can minimalistic shoes have benefit in terms of changing strike pattern? Absolutely, right? Can they potentially cause some intrinsic muscle hypertrophy and that be a good thing? Absolutely. But should you run in them every day as a runner? Probably not, right? Could they have their place in doing a speed workout or a couple things throughout the day, a tempo workout? Absolutely. But they definitely shouldn't be what your runner is running in every day. So now we're going to talk about the opposite end of the spectrum. So now we're going to talk about maximalist shoes. A few years ago, the Hoka shoe came out, and it was the cool thing on the market. It's what everybody wanted. All the teenage kids and college kids were wearing the Hoka shoes, and now everybody wants to be a Hoka shoe. And I absolutely hate that Ultra has created one of these. So if you're not familiar with the Ultra shoe was literally designed to be a minimalistic shoe. It was supposed to mimic this kind of grounding reaction and a very low heel to toe drop. And even Ultra now has copied the Hoka design to be a maximalist design because that's what everybody wants to buy because it was the cool, trendy thing to do. But what we've seen in terms of running mechanics is that there's an increased loading rate when runners transition from a traditional running shoe to a maximalist shoe. And there's a little to no change seen in running mechanics with transition from a traditional shoe to a maximalist shoe. So there's no added benefit of changing any sort of strike pattern, and there's this increased loading rate. So arguably, it actually may increase injury rates by switching to a maximalist shoe. And I think that this is a really important takeaway for your patients who might be coming in with stress reactions. I think people often think, well, I've had this stress reaction and maybe it's directly related to the way I contacted the ground. And maybe I'd gone from this traditional shoe to a barefoot shoe and that caused my stress reaction. So now I'm going to swing to the opposite end of the spectrum and I'm going to get this maximalist shoe. But what we see is there's more ground reaction contact time, there's more ground contact time and this increased loading rate. So you might actually just put that person with the prior stress reaction at an increased risk for injury if you put them in the maximalist shoe. All right. And if you thought we were done talking about cool shoes, we are not. So if you're not familiar with super shoes kind of blew up on the market a couple years ago when the marathon world record time was broken by this guy. And it couldn't have been that he was an elite athlete or that he had maybe trained his whole life to run this marathon at this pace. It was definitely the shoe that changed the game for him, right? And it was definitely the shoe that caused his increased performance level. And Nike took this and ran with it in terms of performance. And what we see is that super shoes do have their place in increasing performance level. That part is evident, but you also have to run fast enough to get that pop off of the carbon fiber. And the majority of people who are running in these at the recreational level do not run fast enough to get that added benefit that the elite runners are seeing from running in carbon fiber. And one thing we do now know is that the super shoes, specifically with the carbon plated super shoes, have an increased rate of bony stress reactions to the navicular. And that's going to come up here in some future slides. So something to keep, again, in the back of your mind. Could these have their place on race day or on a speed work day for your track athlete? Absolutely. But should they be running in them every day? Probably not. All right. So just some basic shoe prescription rules. So take in summary all the things that I just gave you, some key takeaways if you remember nothing else. These are some good takeaways that you might want to know for the extremely pes planus person or that pes cavus. The pes planus person is typically going to need increased rigidity. Typically, a pes planus individual has a flexible foot. Not always, but typically they're flexible. So increased rigidity in the rear foot and midfoot is going to help control that excessive pronation and flexibility throughout the rear foot and forefoot. You're going to typically want to put this person in a stability shoe. Again, majority of what's on the market today is a stability shoe. You may want lateral beveling if you're not putting them in a custom orthotic, or you might want to look for guide rails or some sort of internal bracing system to help provide additional control, or you might want to go that route of the traditional motion control shoe with a medial post or some midfoot stability. But again, there are very few shoes that actually look like that today on the market. And the pes cavus person, you might want to look for a shoe that provides a little bit of midfoot flexibility, not necessarily flexibility throughout the entire shoe, but some flexibility in the midfoot. And you might ask yourself why. So think back to gait mechanics, right? And what should happen at mid stance and through the midfoot. The foot should become adaptable at that point and it should pronate a little bit. So looking for a shoe that has a little bit of flexibility in the midfoot might allow for that extra pronation at mid stance. A couple things not related to athletics. So I've talked a lot about running related injuries, but if you're fitting the patient who's potentially diabetic and you're concerned about wound care, neuropathy, and those sensory issues, you're typically going to look for a shoe that has extra depth to prevent any sort of friction in the shoe, any sort of rubbing. Oftentimes these need to be custom molded to the patient. And it needs to, again, be super deep because these people are typically going to have a custom molded orthotic and they need to be able to accept the orthotic. Traditionally, the diabetic shoe was that SAS shoe on the bottom and it was an ugly shoe and people did not want to wear it. And they were not compliant in wearing these shoes for the most part. Now we have much nicer things. So I included the picture of the ortho feet. That's a much more attractive shoe, I think, for most people when they have to transition to a diabetic shoe. It has a nice wide toe box and it's really deep on the inside, and it has these layers that can be removed of the orthotics that come in the shoe to allow for a custom one to be put in place if you need it to. So we're going to kind of summarize shoes. Some of the important things to note is you have to know what kind of shoe you're working with and what kind of activity level is important to the patient, what their functional level is. Sometimes you can't change that, right? Like I often say that one of the coolest orthotic designs, and it's not an orthotic lecture, but one of the coolest orthotic designs I've ever made was for an Irish step dancer. So I had to work with that shoe on the top right to get something in that shoe, but she couldn't change the shoe that she had to perform her activity in. Sometimes it's working with an athlete that has to wear cleats and they're not safe to switch to a turf shoe or a sneaker for their sport, and they have to be in a cleat. And oftentimes you'll find that soccer athletes specifically like their shoes really tight. So how do you educate that person who says, I can't feel the ball if you make me go up a size in shoe? And they potentially have a nerve pathology because they're tying their shoes too tight, right? Sometimes you have to work with the shoe that you have, or maybe it's a dress shoe based on the person's occupation, or maybe it's that running shoe that you're educating patients on. So some key takeaways here, things you might want to consider. If you're working with an orthotic, you may need to increase the shoe size and the width to accommodate the device depth that you're going to have to put in the shoe. And you need to understand your patient's individual needs, right? At the end of the day, just like I said in that last slide, function and activity may dictate the type of shoe that is worn, and you might not be able to change that at the end of the day, right? But what can you educate them once they take their shoes off and doing to help protect their feet moving forward? All right, so now we're going to kind of put all this together with two cases here at the end. So the first one was a patient that was referred to me by another PT in the network. She was a tough chronic pain patient. She had a complex surgical history. So she'd had multiple bunion procedures, hammer toe correction, a neuroma resection about a year prior to coming to see me. And about 6 months after that first surgery, and 6 months again prior to seeing me for evaluation, she had a fibular stabilization surgery. And the provider she was seeing was an excellent chronic pain specialist. And they reached out to me and said, I think a lot of this is chronic pain, but she just can't get over this medial foot pain, and I've kind of hit a wall, and at this point I'd like you to take a look at her and just see if you have any ideas that are different than what I'm currently doing. And again, she was kind of that typical extremely frustrated chronic pain patient. She was in tears during the evaluation about what all she had been through, and honestly, and being referred to yet another provider to take a look at her foot. And I love this image up here. I found this, I will disclose I took this straight from Google Images. I didn't cite it, but I love this image up here at the top for plantar fasciitis. And she'd been treating her foot for this medial foot pain, and she pinpoints to that spot right there on her foot. And instantly I was kind of like, well, that's not your medial calcaneal tubercle. And I'm not quite sure if that's medial band of the plantar fascia. I think that might be a flexor tendon. And so at that point, I'm starting to get some history from her about shoes and all the shoes she's tried. She's been to the local running store to try shoes, and she tells me, they had to special order these, and it's really hard for me to find a shoe that fits me. And she was this super short, wide foot. And so she says, they ordered these special Brooks for me in a wide. And so I take them apart and I pull out the insole out of the Brooks shoe that she was wearing. And it was wide enough for her foot, but it was about 2 sizes too long for her. And it was the smallest size they could even order for her. And I instantly knew at that point she was constantly clawing and gripping her toes in the shoe because none of her shoes fit. They were all too long for her. So what was going on in this case was she had a flexor tendinopathy, and the spot that she pinpointed was not her plantar fascia, but it actually was her FHL and FDL that was irritated. And fixing the shoe size was the key to helping her, right? I treated her with some extracorporeal shockwave to address the tendonitis. We did some eccentric loading. All those things were important in calming down the inflammation she had and addressing some of those current impairments. But if I didn't change the size of her shoe, she was going to come back to me again. And honestly, I hit a wall with treating this patient because I couldn't find a shoe that would fit this woman. She was a size 5 shoe, and an extra wide, a 2E. And so I ended up actually reaching out to one of our pediatric therapists and said, what do you put kids in AFOs in? Because you got to put braces and shoes for kids that are extra wide at times. So what do you do in those cases? And they gave me a couple New Balance options. And this woman was great. She went on Amazon and she ordered 10 different pairs of shoes. And she came in with her 2 giant bags into her next PT session. And we tried on, you know, 2 differing sizes between a half and a 5 and a 5.5, and anywhere from an E to a 2E to a 4E in different styles of New Balances. And she found the one that fit her orthotics, fit her foot, and it felt good at the end of the day. And they only ended up being $45, and she can continually order them on Amazon. So it was a win for everybody. But in this case, it was all about finding the right shoe and being able to kind of deconstruct that shoe and take a look at different pieces of it. You know, look at the toe box, how it fit her, how the width of the shoe fit her, and ultimately how the length of it fit her. And I'm going to give you one more case here before we kind of wrap up. And this is another one with, was the shoe potentially a predisposing factor, right? And it definitely was in the previous case. So this is a patient that I'm currently treating, actually. She's a 19-year-old collegiate female track sprinter. She has a history of anterior dorsal ankle pain. She's been treated for an anterior tib tendinopathy for about 2 weeks without improvement. And a colleague kind of grabs me and says, "Hey, we've been treating this conservatively for two weeks, and things just really aren't improving. And not only are they not improving, but at this point, her performance is decreasing. And this weekend, she actually scratched 2 events at regionals because she was in so much pain and she had started limping. Do you mind taking a look at it and see what you think?" And honestly, even before she spoke, I felt pretty confident that I was about to ruin her day, and tell her that, I had high suspicion for a stress reaction. But, as a good clinician, I fully evaluated her, and, my suspicion only became higher at the end of that evaluation. And so I referred her to primary care sports medicine, where she received an x-ray and then ultimately an MRI, which confirmed that she did, in fact, have a navicular stress reaction. And it actually wasn't until I was prepping this lecture that I thought back to, I wonder if the shoes she was training in were a carbon-plated shoe, based on what I now know about navicular stress reactions. And there was nothing else glaring for this girl, in terms of reds, like super good sleep hygiene, healthy, appropriate intake, appropriate progression. She was a sophomore. She didn't significantly increase training loads, didn't change, training volume significantly, didn't change surfaces. But the one thing she changed was this was the first season that she ran in a carbon-plated shoe. She did have a slight increase in time and spikes, but again, nothing to speak of outside of that. But in high school, she did not run in a carbon-plated shoe. In her freshman year, she did not run in a carbon-plated shoe. But every single practice and race, she ran in a carbon-plated shoe this season. So that being said, maybe it was the slight increase in training and that slight change in cross training, but something to think about. Maybe that carbon shoe did contribute, and we've had discussions about injury rates of navicular stress reactions in carbon-plated shoes. And in the future, she plans to utilize these only for speed work and for race day, and to have a shoe that she's also training in that's not carbon-plated shoe for the rest of her time on the track. And I think that that's going to be a really good plan for her moving forward. So some clinical bottom lines for you to kind of take away from this talk is the shoe market is constantly evolving. I can't possibly know it all as a clinician. I don't think you can possibly know it all in terms of the things that are constantly changing in shoes, unless you own a shoe store and you're buying shoes. The people who buy the shoes and they get to test the shoes and they get to constantly see the design, those are the people who know shoes inside and out. But you as a clinician should be able to describe the basics in terms of shoe construction and describe what you're looking for so that you can guide patients on appropriate footwear choices. And ultimately, at the end of the day, I highly recommend that you build a trusted relationship with a reputable shoe store that you can talk to. You can pick up the phone. Our local shoe store here, I often pick up the phone and talk to the owner and say, "Hey, I had this difficult patient. It's got this complex medical history, and this is what I'm looking for. I'm looking for a stability shoe that's not going to overcorrect them with their custom orthotic, doesn't have lateral beveling, doesn't have a medial post, but anything else that fits their foot, fits that orthotic potentially that I made in those cases, and matches that description. you can put them in and they like. And I find that that's a much better experience for patients than trying to lock them into a brand. And brands and styles change. Now, again, the Brooks shoe that I liked last year is not the same Brooks shoe today, right? Things change and evolve. So develop a good relationship with someone that you can constantly have those conversations and be able to describe the basics in terms of what you're looking for in shoes. All right. Any questions for me at this point?
So please feel free to type your question in the chat or unmute yourself and speak up. While we're waiting for people to do that, going back to the barefoot running, my understanding of those studies are they changed the shoe without changing the running volume. Is that accurate or is that
Yes.
incorrect?
Yeah. The only thing they changed was the shoe.
Okay, so if you are going to change to a minimalistic shoe, my understanding is the recommendation is you need to drop your volume massively and then build back up. Is that accurate?
Yeah, I would agree with that. And I would say think about other principles in terms of running, right? Other principles involve this 10% rule. So we should probably back it up and then also increase volume by 10% at the same time. Yeah. Almost treat this person like they had an injury and you're starting really low volume and you're adding that 10% each week.
Okay. Thank you. Another question is, are there any shoes to tell athletes to stay away from?
Nike Frees would be one of my recommendations. Don't ever put anybody in a Nike Free. And then I think that's highly dependent on the foot type in front of you, and what their gait mechanics look like, right? Don't put the person who's, a pes cavus foot, an excessive supinator, and a motion control shoe with some medial rear foot posting. Also, things you may potentially want to avoid, again, that lateral beveling in the person who's extremely pes cavus. But for the most part, that's highly dependable on the patient in front of you. But I would say some of my hard rules are I never would prescribe like a Nike Free extremely flexible shoe to pretty much any athlete. And I would highly caution most recreational athletes from buying a carbon plated shoe unless you feel confident in their ability to run at a certain level.
Thank you. Other questions? Okay. If you think of other questions, please feel free to reach out to either Dr. Scifers or myself. Please make sure that at the end of this presentation, you complete the quiz and the course evaluation. Course evaluation helps us always improve these presentations and come up with new ideas to help you guys. So unless anybody has any other questions, we will see you next month. Thank you very much.